with the AIMS Nagpur. Thanks to Dr. Suchita Mundle. Today I said relax feeling, friends, because we know that APH is a nightmare for all of us. And today, all amazing faculties for APH are going to discuss this problem. So I think we should be relaxed. Now we are entering in the celebration mode of Diwali with lots of blessings from the gods and goddesses. And I think it is very important to discuss this because this discussion will enlighten all PG students to add light in the patient's life. So it is very important discussion. So this in reality, in a true sense, Diwali to put a light or lighten and even Diwali. So the first lamp will be started by our youngest buddy, Dr. Chandana Prasad. So she has dared to present this PPH case, and to maintain that light, our examiners, they will help her. So welcome examiners, Dr. Padma Shukla and Dr. Mosmi Tadas. Now some cases are really very difficult and we need to take off help of n number of diyas, n number of solutions. So much we know we need to have a proper lamps for that. So I think here is Dr. Aruna Nigam. She is going to throw wonderful, she is going to show wonderful cases and it will definitely enlighten all of us. So welcome Dr. Aruna Nigam. And the chairpersons are there to again maintain that Diya series. Dr. Archana Verma, Dr. Shipra Sonkus are there. So welcome chairpersons. And our this MOC, Dr. Neha Gangne, really she has taken very hard efforts to create all these things and to maintain this webinar. And also, how can I forget the backbones, Dr. Anuja Bhalera, Dr. Prachi Dikshit, Dr. Bhakti Gurza, Dr. Pragati Kirkar, who all are helping for this wonderful PG activity so that the Diya series or the light of Diwali should go to each and every, because that is our main purpose of being that they should enlighten their life also with different Diyas. So happy Diwali to all and welcome you all. Again, I request all PGs and all the examiners are here from the different areas of the India. So we are having wonderful conference, a mega event, Nagpur Hysteroscopy Carnival on 15th, 16th and 17th of December 2023 with 4 international faculties along with Dr. Osama from Egypt, then from Italy, 3 faculties are there. Dr. Gubini, you must be doing the Gubini's mini receptoscope, then Dr. Lugi, then Dr. Mario Francini. So in all IIG people, there's the Indian Association of Endoscopists. So these are also involved with us. So you just have this, everybody will get that opportunity to interact with all national and international faculties. So take this opportunity, avail this opportunity. So thank you very much.
Thank you, ma'am. Now I invite Dr. Pragati, ma'am, to please present the vote of thanks.
Thank you, Dr. Neha. It's all a very good evening to all of you at this festive evening. Here in Nagpur, we celebrate, after Dashera, we celebrate Kojagiri. Again, as Dr. Sushma said about Diwali and Diyas, this Kojagiri is also a festival of, happiness, light. The full moon is celebrated. So here, again, we are here to spread the light in day and night, because ours is a branch where we get any emergency at whatever time. So today I am here to present on behalf of Nagpur OBGYN Society in association with All India Institute of Medical Sciences, Nagpur. Today is our 14th series of PG Star, which is running very well throughout the country, throughout the globe. And here I thank, first of all, our examiners, Dr. Padma Shukla from Riva and Dr. Mosmi Tadas from our own GMC Nagpur. And today's presenter is Dr. Chandana Prasad, who will be presenting the case on antepartum hemorrhage. I extend my heartfelt thanks to today's speaker, Dr. Aruna Nigam, who is accepted to speak on perioperative challenges in managing APH. It's going to be a thrilling session. And to chair the session, we have esteemed Dr. Archana Verma and Dr. Shipra Sonkustre. Thank you, ma'am, for chairing the session. How can I forget my backbone team who are working constantly since last 7 months to spread knowledge of light? That is Dr. Anuja Bhalera, Dr. Prachi Dikshit, and Dr. Bhakti Gurza. Constantly, after searching cases, searching topics, searching examiners, getting so esteemed good examiners and good chairpersons and good faculties and good speakers. thank you all for constantly working for it. And today's MOC, Dr. Neha Kangne, she has been instrumental in connecting. We are also glad, Dr. Neha, to connect with you and hope to conduct many more programs in coming time. And again, as Secretary of NOJS, I request all the PGs who have joined here, don't miss the opportunity to present on the national platform, which will be a National Hysteroscopy Carnival in December 15, 16, 17. Present paper, do attend the conference and learn the art of hysteroscopy. Our president, Dr. Sushma Deshmukh, is herself a magician. She does a very beautiful hysteroscopy and she teaches it so well, holding your hand, and she will guide you through the hysteroscope. So do attend. Thank you all. Without a delay, I hand over mic to our MOC, Dr. Neha.
Thank you, ma'am. Now I would like to introduce our examiners for today. Our first examiner is Dr. Padma Shukla. She is Associate Professor from REVA. Her special interests are she has received Best Paper in AICOG 2012 as well as 2016. She received Young Talents Award in 2022 and Dr. Darusha Award in 2022. She has more than 15 publications in national and international journals and many chapters in various books. She is executive editor of Pan Asian Journal. And our second examiner for today is Dr. Maushmi Taras, who's known by all. She is associate professor at Government Medical College at Nagpur since the past 10 years. She is a fellow of Indian College of Obs-Gynae and life member of IMS. She is UG and PG examiner both in MUHS. She has special interests in high-risk obstetrics, infertility, gynae endoscopy, vaginal surgeries, and clinical research. She has received a special prize for presentation in Gynecon. Many poster and papers she has presented in various conferences and has been faculty in various conferences. She has n number of publications in many national and international journals, and she is also a peer reviewer for Jogi and other journals. She is the principal investigator in Mooli project at GMC and national faculty in Moot Court. So I welcome you both, ma'am. And our case presenter for today is Dr. Chandana Prasad, who is a second-year resident at All India Institute of Medical Sciences, Nagpur. And she is the first postgraduate to join our department. So I welcome you, Dr. Chandana. Please start.
Thank you, ma'am. Before you start, I would like to say a very good evening, all of you. And thank you so much for inviting me as a teacher for this case presentation. All the best, Dr. Chandana. I hope you will do good. All the best.
Thank you, ma'am. Good evening.
All the best, Dr. Chandana.
Thank you, ma'am. Good evening, esteemed faculties. Today, I am presenting a case of antepartum hemorrhage. My patient, Mrs. X, is a 31-year-old housewife, a graduate, married to Mr. Y, who is a shop owner, hailing from Mowat, Nagpur, which is 100 kilometers from our hospital, belonging to modified Kupuswami lower middle socioeconomic class, with a Gravida 3, Para 1, Living 1, and Abortion 1, with her LMP being 23rd of February 2023, her estimated date of delivery being 30th of November 2023, and her current gestational age is 36 weeks. She presented to us at 32 weeks of gestation with complaints of bleeding PV, which was bright red in color, minimal in amount, and painless. There was no history of pain abdomen or leaking PV. There was no history of trauma or coitus. And she was diagnosed as a case of placenta previa at 5th month of gestation. She had no prior history of bleeding per vaginum before reporting to AIMS. She was admitted at 32 weeks and was managed conservatively and was evaluated and was found to have adherent placenta on MRI. There was no history of raised BP records. History of present pregnancy. First trimester, her pregnancy was confirmed by urine pregnancy test done 2 weeks after missed periods. She was started on folic acid supplements at 2 months of gestation. Dating scan was corresponding to her LMP. Her baseline investigations were found to be normal, and there was no history of bleeding or spotting per vaginum in first trimester. There was no history of excessive vomiting, fever with rash, or exposure to drugs or radiation in first trimester. Her NT-NB scan was found to be normal. Her blood group is AB positive. Second trimester, Quickening was felt at 5th month of gestation, and she was started on iron and calcium supplements from 4th month and is still continuing. She received 2 doses of injection TD at 5th and 6th month of gestation. Her ultrasound at 5th month was said to have a low-lying placenta with invasion. There was no history of bleeding or spotting per vaginum in her second trimester, and BP records at every visit were normal. Third trimester, she continued to appreciate fetal movements well, and her serial ultrasound showed normal interval growth with adherent placenta previa. Patient had first episode of bleeding per vaginum at 32 weeks when she reported to AIMS and was managed conservatively and has been admitted since then. She had no further bleeding episodes after admission. Past obstetric history. She's married since 6 years. It is a non-consanguineous marriage. Her first pregnancy was 5 years ago, where she had a missed abortion and suction evacuation was done for the same at 2.5 months of gestational age. Her second pregnancy, the child is now 2 years, and she was antenatally diagnosed with a low-lying placenta, which was asymptomatic and had an elective cesarean delivery at 37 weeks of gestation. Intraoperatively, there was a low-lying placenta with a succensurate lobe, and she received 1 PRBC transfusion. She delivered a live-born girl baby weighing 2.8 kgs with a good UPCAR score, who was breastfed, immunized, and achieved normal milestones. She's alive and healthy now. G3 is her current pregnancy. Menstrual history, she attained menarche at the age of 14 years. Her cycles were regular, once in 28 to 30 days with a bleeding for 4 to 5 days, with her last menstrual period being 22nd of February of 2023 and expected date being 29th of November 2023, gestational age being 36 weeks. Past surgical history, she had a significant history of open myomectomy done in 2018. The details of surgery are not available. There is no history of chronic illness like hypertension, diabetes, tuberculosis, or asthma, and there is no history of allergies. Family history, there is no history of hypertension, diabetes, congenital anomalies, or twins in the family. Personal history, she consumes a mixed diet, has normal sleep and appetite with regular bowel and bladder habits and no addictions. Dietary history based on 24-hour recall method. Her daily calorie intake is around 2,200 to 2,300 kilocalories per day and consumes an average of 60 grams of protein per day. General physical examination. She was conscious, coherent, well-oriented, moderately built and nourished. Height 156 centimeters and pre-pregnancy weight 54 with her pre-pregnancy BMI of 22.5 kgs per meter square. Present weight is 63 kgs and she has a weight gain of 9 kgs throughout the pregnancy. There was no pallor, icterus, fetal edema, or lymphadenopathy. Her pulse rate was 94 beats per minute, which was regular in rhythm, normal in volume and character. Her blood pressure was 108/74. Her respiratory rate was 16 breaths per minute. Respiratory system examination showed normal vesicular breath sounds heard bilaterally, and there were no added sounds. On cardiovascular examination, S1 and S2 heart sounds were heard, which were normal, and there were no murmurs. On obstetric examination, on inspection, abdomen was distended longitudinally, linea nigra and stria gravidarum was seen, umbilicus was central and everted, a transverse suprapubic scar of 10 centimeters length, healed with primary intention seen, and there were no dilated veins or sinuses. On palpation, uterus was relaxed and non-tender, and the fundal height corresponded to 36 weeks of gestation. Symphysis fundal height was 35 centimeters. Abdominal circumference measured 90 centimeters at the umbilicus. Fundal grip was suggestive of breech, and the pelvic grip was suggestive of head, which was mobile, that is 5/5 palpable. It was a cephalic presentation. There was no scar tenderness. On auscultation, fetal heart sound was heard over the left spino-umbilical line, 144 beats per minute and regular. On local examination, there were no varicosities. On per speculum examination, there was no bleeding, there was no polyp or erosions. Case summary, ma'am. My patient, Mrs. X, a 31-year-old gravida 3 para 1 living one with one abortion at 36 weeks of gestation with regular antenatal checkups, was admitted with complaints of bleeding per vaginum at 7th month of gestation and was managed conservatively. There was no history of hypertension and trauma. She had a significant history of myomectomy and previous LSCS in view of low-lying placenta. On examination, she was vitally stable. The height of uterus corresponded to the period of gestation with a longitudinal-like cephalic presentation. Uterus was relaxed and non-tender. Provisional diagnosis. My patient is a 31-year-old, gravida 3, para 1, living 1, abortion 1, with history of myomectomy and cesarean delivery done 2 years ago at 36 weeks of gestation with symptomatic morbidly adherent placenta previa and is on conservative management. Investigations. Her first trimester investigations were blood group was AB positive, hemoglobin was 9.5 grams, TSH was normal, that is 1.2, viral markers were non-reactive, HPLC showed a normal AA pattern, and in second trimester, her HP was 10.2 with a normal TSH and urine routine. On 20th of October, her hemoglobin was 11.4, PT-INR was 0.9, which was normal, and LFT and KFT were within normal limits. Ultrasound. Ultrasound NT-NV scan done at 13 weeks was corresponding with a NT of 1.6 mm and NB was seen. Placenta was seen developing anteriorly. Ultrasound done at 24 weeks of gestation showed a low-lying placenta covering the os and invading into the myometrium, and there were no gross congenital anomalies. Ultrasound done at 27 weeks showed placenta covering the os, and ultrasound done at 35 weeks of gestation showed placenta anteriorly completely covering the os, invading the myometrium with loss of fat planes with the urinary bladder. And the interval growth was adequate. These are our ultrasound pictures, which were suggestive of placenta accreta. MRI was done, which showed a single gestational sac with placenta seen covering internal os with loss of fat planes with the urinary bladder, but there was no obvious bladder infiltration suggestive of placenta percreta.
Do you want to complete your, or is it complete?
It's completed, ma'am.
So what's your final diagnosis then?
My diagnosis is, my patient is a 31-year-old, gravida 3, para 1, living 1, at 36 weeks of gestation with a history of myomectomy and cesarean delivery, which was done 2 years ago, with symptomatic morbidly adherent placenta, who is currently on conservative management.
She is 36 weeks of gestation and at present she is antenatal.
Yes, ma'am.
Okay, 36 weeks more with morbidly adherent placenta. Okay, so can you tell us like how will you go about this patient for management?
Ma'am, she initially presented at 32 weeks with complaints of spotting PV, which was minimal and painless. At that time, we have admitted her and managed her conservatively. We have monitored her vitals and her bleeding has stopped. And then we have arranged adequate blood and blood products and have investigated further, as she had a previous history of low-lying placenta. We have investigated further for any adherent placenta, and on MRI, we found that it was a placenta percreta. And we will plan for an elective delivery at 37 weeks of gestation.
Ideally, when a patient of percreta is diagnosed, at what gestation you have to terminate the pregnancy?
Ma'am, according to the ACOG guidelines, we have to terminate between 34 weeks to 35.6 weeks of gestation. But according to Green Top guidelines, we can continue the pregnancy till 37 weeks of gestation.
But your patient is symptomatic, na? So why you want to wait till 37 weeks?
Ma'am, she had one episode of spotting PV at 32 weeks and it has resolved. She did not have further episodes.
You have written 2 years ago, 36 weeks of gestation symptomatic morbidly adherent previa on conservative management.
Because in your diagnosis, you yourself has mentioned at present she is symptomatic. So this word then you shouldn't have mentioned. Like at present she is not symptomatic. That means.
Currently, she's asymptomatic, ma'am, but
Yeah.
she
So
had one
currently she is
episode.
asymptomatic, but
Yes,
at
ma'am.
32 weeks she had bleeding, but now she is not symptomatic. Okay.
Yes, ma'am.
So that's what I was trying to ask you, what preparedness you will keep, or like now it is already diagnosed, okay? So
Yes.
you are in a good position to manage this patient because your patient you are already diagnosed. Your diagnosis in hand. She's a previous cesarean with myomectomy, with placenta accreta, and with not invasion in the bladder. So you are quite lucky. So still, but she is placenta accreta. She
Yes.
may go in massive PPH. So
Yes.
what preparedness you will keep? Like how will you plan a surgery?
Ma'am, preoperatively, we would like to optimize her hemoglobin and we will arrange adequate blood and blood products.
How much? How many you will arrange? 1, 2, 4?
Ma'am, minimum 4 PRBCs and platelets and FFPs in the same ratio, ma'am. And
so you'll go in for massive transfusion protocol. You'll have to initiate massive transfusion protocol. Okay.
yes, ma'am.
Because you may require in such patients.
Yes.
Okay. And what else you will keep ready?
Ma'am, it will require a multidisciplinary team approach. So we will inform the senior anesthesiologist, the transfusionist, and consent should be taken.
Any other specialty you want to involve?
Urologist should be informed, ma'am.
Yes.
And interventional radiologist if there is a need for embolization.
If the facilities are available.
Yes.
That is conditional. Yeah. And what about the surgery? Before surgery, what are the investigation you will get done?
Ma'am, baseline investigations, her blood grouping, blood should be cross-matched. Her baseline hemoglobin, WBC and platelet count, or coagulation profile, prothrombin time, fibrinogen levels, and D-dimer should be done, ma'am. And routine preoperative investigations like liver and renal function test, viral markers, and ultrasound to confirm the location of placenta.
Which one is better to localize the placenta, MRI or ultrasonography?
Ma'am, both MRI and ultrasound have same diagnostic accuracy in localizing the placenta, but MRI is useful if there is a posterior placenta and to know the invasion and if there is extension into the parametrium.
Yes, very good. Then before preparing, doing the surgery, what will be your plan? Like you have arranged you have informed the multidisciplinary team, and you have done all the investigation, and you have arranged the blood, right?
Yes.
Blood and blood product.
Yes.
And now, what will be your plan? Like before doing any surgery, we plan, especially for the placenta accreta. So, what will be your type of incision in this case? And how you will proceed? What will be your plan?
Oh, ma'am, we will prefer
you are doing the surgery. Although it should be done by the senior obstetrician.
Yeah, who should do this surgery? Like, what will you prefer? Who will you prefer doing the surgery?
I'm senior obstetrician who has experience, and the senior anesthesiologist and urologist should be available.
Senior obstetrician should be skilled in doing what? Like Means only obstetric hysterectomy, or then what else?
Yes, anything else that the competency should be there.
Pelvic surgeries, ma'am.
Like what will be required in this patient?
And there may be chances of injury to the bladder. So bladder repair.
It will be done by the urologist,
Okay, you
right?
should, okay, you may do the bladder repair. You may also do it.
Hmm.
But apart from bladder,
Uh,
like pelvic
What
surgery, what
else?
type?
Ligation of internal iliac arteries, uterine artery and internal iliac artery ligation.
Okay. So, when how will you like proceed? How will you open the abdomen? After opening the abdomen, how will you go in for doing
No, but
extracting the baby? Like
type of
incision,
incision of the abdomen
type
is
of
also
incision.
important, na?
Yeah. Type of incision over the abdomen, over the uterus. Which incision you will prefer?
Ma'am, vertical incision over the abdomen is preferred as it gives us more space to operate. And on the uterus, we should give an incision avoiding the placenta. Vertical incision is given, ma'am.
Okay, vertical incision will be given. Okay, then.
And after delivery of the baby, immediate cord clamping is done. And the uterine incision is closed immediately, and we proceed with the hysterectomy.
Okay. Is there any role of conservative surgery in such patients?
Ma'am, in my patient, since she's already, this is her second living issue, we would prefer to proceed with obstetric hysterectomy, but we can also do a conservative management if the patient is willing for uterine preservation and for further fertility.
Okay, like if this patient would not be antenatally diagnosed, like you found a surprise on the table, okay, and you're trying to remove the placenta, but you remove the placenta in piecemeal, okay.
Yes, ma'am.
Then what will you do?
Ma'am, if we have diagnosed it intraoperatively, the
Because
placenta.
you don't know now whether this placenta is accreta or not, because it was not diagnosed. She was an unbooked patient, okay. So then,
Ma'am, piecemeal that has been removed is removed, and the left part and the remaining part is left inside, and we can follow up the patient.
Your patient will bleed, dear. So what you will do?
Can you leave the placenta like that only? See, half of the placenta you have removed. Some part is remaining. So what will happen to that placenta? Will it bleed or not? Are there any role, or is there any role for conservative management, or what are the methods, conservative surgeries you can do in such patients in undiagnosed cases of accreta?
Methotrexate can be given. There is going to be autolysis and necrosis of the placenta.
But how many cases, like what are the disadvantages of giving methotrexate?
It is a hepatotoxic drug, ma'am.
But what will happen? What happens later on? Is it like successful? Or patient will land into what?
Ma'am, patient may end up with sepsis.
Mostly these patients, whenever you give methotrexate, instead of autolysis, the patient, if the placenta remains in situ, the patient usually they go in sepsis most of the times. And then they land in secondary PPH, then you have to do the obstetric hysterectomy later on. Okay.
Yes.
So only few patients, or if a very less part of placenta is remaining, so it may be this methotrexate is successful. But usually nowadays methotrexate treatment is not recommended.
Yes.
So apart from methotrexate, what else can you do? Are there any methods mentioned which can be applied? Newer surgery which can be done?
Abdomen is already open. So
Yes.
what you will do? Any surgical method?
There are so many like
We proceed
conservative.
with pelvic devascularization, ma'am, stepwise devascularization,
Okay.
and uterine artery ligation, internal iliac artery ligation, embolization.
All you will do in one sitting. How can you do uterine? Okay, you can do uterine, internal iliac
Internal iliac
ligation.
ligation.
And how can you do embolization also at the same time? If beforehand, then what you should have done if you want to do embolization?
Preoperatively placement of stents, catheters
Yes,
should be
yes,
done.
you have
We are
to keep
planning
the
for
uterine
embolization.
catheters in situ. And then on table, then you can infiltrate that gel, isn't it?
Yes, ma'am.
So before that, you have to keep those catheters in situ. And then if you want, like you feel like that the patient is bleeding heavily, then you can infiltrate that gel, isn't it?
Yes, ma'am.
So beforehand, you have to keep all these things ready. And after doing like uterine artery embolization, do you want to preserve the uterus or you have to remove the uterus then?
We want to
What will you do?
preserve the uterus, ma'am.
You will preserve with the uterus, with placenta in situ. Because your placenta is still there, no, inside. So what will you do?
Ma'am, if she's willing for further conception, we will preserve the uterus and we will ask the patient to come for regular follow-up.
Okay. Okay, what are the other methods? Like any other method do you know for conservative treatment?
Suppose it is diagnosed placenta accreta, and as it is in your case, but if the placenta comes out slightly, then what you will do? You will remove the placenta or you will leave?
Ma'am, if it is placenta accreta, attempts at manual removal of placenta will result in profuse hemorrhage. So we will
Yes.
not try removing the placenta and directly proceed with the hysterectomy, ma'am.
Okay. Sometimes what happens, what madam is asking you, that you have removed the placenta in piecemeal, then there will be heavy bleeding, right?
Yes, ma'am.
And how you will control that bleeding? Are there any particular sutures which you know? Like if you have removed the placenta and there is bleeding is still present. You have removed almost all the placenta, but as it is accreta, there will be bleeding. So how can you control this bleeding? Any suture, apart from this devascularization?
Hemostatic sutures can be applied at the placental bed.
Yes.
That is figure of 8 or Cho sutures. Figure of 8 sutures, ma'am.
You are muted, Dr. Mosmi. You are muted.
So what are the different types of sutures you can take? Can you name some sutures which can be taken for to control this placental bed bleeding? Chandana, are you there?
Yes, ma'am.
Okay. So what are the various different types of sutures you can take to control the bleeding?
Sutures at the cervicoisthmic junction and
Okay, now in this patient, you are doing obstetric hysterectomy. Suppose you are doing okay.
Yes, ma'am.
So which type of hysterectomy you will go in for?
Ma'am, we will go for a total hysterectomy as the placenta is low lying.
Okay. We will go in for total hysterectomy, right?
Yes, ma'am.
So you will in such type of patients in placenta previa, if the patient lands in obstetric hysterectomy, you have to always do total hysterectomy.
Hysterectomy.
Yeah, because the placental bed is below. So
Yes.
if you do subtotal hysterectomy, again it will there will be bleeding from the lower uterine segment. Okay. And this is here you have to take the cervicoischemic stitches. You have correctly said that you have to take cervicoischemic stitches. Are there any other stitches you can take over the uterus if there is bleeding? Can you name some stitches?
Ma'am, hemostatic sutures, that is B-link and Heyman sutures.
B-link, Heyman's, and in cesarean section, suppose you reopen the uterus, patient is normally delivered. Okay.
Yes.
Normal delivery patient you have opened in view of PPH. So, can you take B-link?
Yes, ma'am.
Which type of B-link you will take?
Modified B-link suture.
Modified B-link. And which type of suture you are going to use for B-link?
Catgut, ma'am. Chromic catgut.
Chromic catgut. Do you know any disadvantages of B-link, or have you seen, or do you know what can happen with B-link?
No, ma'am.
Okay. So now, suppose a patient comes in the first trimester. Okay, this patient, she has reported to you in which trimester? 5th month, I think so, right?
She came at 32 weeks, ma'am.
32 weeks only. Now, if such a type of patient, she comes in the first trimester, like 31 years old, third gravida with history of open myomectomy, okay?
Yes, ma'am.
So if she comes to you in the first trimester, how will you take the history of this patient? Can you do the triaging of this patient in the first trimester? So what are the historical important points in this patient, which will categorize the patient in high risk category? How do you do risk categorization of these patients, antenatal patients?
Ma'am, first trimester, we will ask if she has any history of bleeding or spotting PV. In past history, she has a significant history of myomectomy and a history of cesarean section done in view of low-lying placenta. She also has a history of curettage in view of missed abortion. These are risk factors for development of an adherent placenta. And
so in the first trimester only, you can categorize this patient that she had two prior surgeries, uterine surgery also, myomectomy also, cesarean also, that too for placenta previa. Okay.
Yes, ma'am.
So in such type of patients, what are the chances of accreta? Placenta previa, previous cesarean.
And she has a history of DNC as well. DNC, multigravida. So there are so many risk factors.
Ma'am, in cases of previous LSES, the risk of placenta accreta is 3%.
Right.
Developing in subsequent pregnancies.
Yes. And in placenta previa, if she is having previa, then? Placenta previa with cesarean.
Previous placenta previa with cesarean, there's a risk of 4.2%, ma'am.
Okay, and if there is 2 cesarean section, then previous 2 cesarean?
Ma'am, previous 2 cesarean, there's a risk of 11%. And in previous 3 cesarean, the risk increases to 40%.
Yes. So now if suppose a patient is there, she has come with 36 weeks. She is not your book patient, okay?
Okay.
She has come with the bleeding PV. Okay.
Yes, ma'am.
So how will you go about in history, examination? and investigations? How will you come to the diagnosis?
Ma'am, if a patient presents at 36 weeks with complaints of bleeding PV, initially I will take her vitals, and if she is not hemodynamically stable, we will proceed to resuscitate, and if she is hemodynamically stable, we will proceed to further examination. And on obstetric examination, we will look for her period of, if the fundal height is corresponding to her period of gestation, we will look if she has any tenderness. And next we will evaluate the fetus. We will assess for fetal heart sounds and do an NST. And investigations, we will send baseline investigations like hemoglobin.
So before that, will you do the local examination?
Yes, ma'am, we will go for a local examination to rule out any local causes, and a per speculum examination. But a per vaginal examination is contraindicated if the patient is unbooked and we know the location of placenta.
Clinically, how will you differentiate between an abruption and a placenta previa? This is a very basic question.
Ma'am, in placenta previa, the bleeding is fresh, painless, and recurrent, whereas in abruptio placenta, the patient...
And causeless. One more is causeless bleeding.
Causeless, yes, ma'am.
Painless and causeless.
Yes, ma'am. In abruptio placenta, the bleeding it depends upon the type of abruption. If it is a revealed abruptio, then there is dark red bleeding which is associated with pain. And on examination in placenta previa, there is no uterine tenderness and there are no contractions. Uterus is relaxed.
Fundal height is?
Fundal height is corresponding to the period of gestation.
And what about the presentation?
Placenta previa, there are more chances of malpresentation, ma'am. In abruptio placenta, the patient presents with pain, and on palpation, tenderness is present. The fundal height is more than the period of gestation, and tonicity.
May or may not be more than. It may be more or it may not be more than.
Yes, ma'am. And the tone is raised.
And the presenting part is, what about the presenting part in placenta previa?
In placenta previa, there are malpresentations, ma'am.
What about the presenting part?
Presenting part is mobile, ma'am.
Mobile? Floating. You mean to say floating?
Floating.
What is
Floating. Okay.
floating? Yeah.
So mostly whenever in placenta previa cases, the presenting part is floating. Okay, it is above the pelvic brim because there is low placenta is low lying in major degree of placentas. Okay.
Yes.
Anything else? Anything else in your examination?
Ma'am, fetal heart sounds, ma'am.
Yeah, it will be there in.
It is good in placenta previa, but whereas in abruptio placenta, fetal heart sounds may be absent.
No, you cannot like that generalize the things. You know, if placenta previa, there is large amount of bleeding, there may be evidence of distress, or even that patient may have IUD. Okay.
Yes, ma'am.
Yes. But in abruption,
So you have to assess the amount of bleeding.
Yes, amount of bleeding you have to assess. Accordingly, the fetal status you can judge. Okay.
Yes.
Then this is okay. One more thing. In abruption, what will you find in a general examination?
On general examination, there is pallor and tachycardia, hypotension.
Pallor will be proportionate to the blood loss.
It is disproportionate to the blood loss, ma'am.
In abruption.
In abruption, yes, ma'am.
In which type of hemorrhage? In abruption, in which type the pallor will be disproportionate?
In concealed type of abruption.
Concealed type of hemorrhage. So the pallor may not be in proportion to the amount of blood loss in abruption.
Yes.
because of concealed hemorrhage. And one more thing, additional finding will be there in abruption. What will be that? In general examination, pallor, in addition to the pallor, apart from pallor, one more thing. Pallor, tachycardia. Third thing, what do you see for pulse then?
Hypotension.
Hypotension. That will be
Blood pressure.
according to the blood loss. Okay. But abruption may be associated, or mostly it is associated with
Raised BP records, ma'am.
with pardon?
Preeclampsia, ma'am.
With preeclampsia. So the most common cause of abruption is preeclampsia. So the BP is usually raised in patients of abruption. They will have edema of feet. They will have all features of preeclampsia. So there are very less causes of abruption other than preeclampsia. The most common cause is preeclampsia. So you will find always, or most of the time, the blood pressure is raised in patients of abruption. So that is one of the important findings. So then will you do the, like what madam has said, you will do the per speculum examination to see whether how is the os, how is the bleeding, is there any external like injuries or any findings over the cervix, any varicosities, cervical polyps and all those things. Okay.
Yes.
Then how will you proceed further for diagnosis? Now clinically you have diagnosed whether it is placenta previa or abruption. Okay. Then you have to confirm your diagnosis. So how will you confirm your diagnosis?
Ma'am, we will proceed with an ultrasound.
Mm-hmm.
Ultrasound with Doppler examination to confirm the diagnosis.
Okay. So which type of ultrasound will you do? Like now there is some, you cannot diagnose or the bladder is not full. You cannot see the placenta properly.
Transvaginal ultrasound is done, ma'am, for localization of the placenta.
So if the patient is bleeding still, you would like to go for transvaginal ultrasound? Yes or no?
We can do a transvaginal ultrasound, ma'am.
Yes, you can do a transvaginal ultrasound even if the patient is bleeding. If you have any diagnostic dilemma, you can do transvaginal ultrasound also. Even if the patient is bleeding, you have to do gently.
Yes.
You don't have to like go up to the cervix. Okay. So you
Yes.
can do it gently. So it has more accuracy, more like sensitivity for diagnosing placenta previa. Transvaginal ultrasound. Yes.
Achha,
Can
can
you
you
tell
tell
me?
me? Oh, sorry.
Yes. No, yes, you can ask.
Can you tell me that patient, if normally situated placenta is there, whether it can be a creta or not? If it is a
Yes, ma'am.
normally situated placenta, yeah.
Yes,
As your
it
patient is
can.
having history of DNC as well.
Yes, ma'am.
Yes, very good. So a normally situated placenta can also have a creta, right?
Okay.
So you have diagnosed that your patient is placenta accreta, right?
Yes,
As
ma'am.
madam said that it is in the early weeks, in this 32 week, ma'am, you said, on 36 weeks, sorry. So how you will proceed now? In emergency, patient has come to you, you have to confirm the diagnosis. Now, what you will do?
Ma'am, based on clinical signs and symptoms and ultrasound, we confirm the diagnosis of placenta accreta. And then we inform the senior obstetrician and involve the multidisciplinary team. And adequate blood is cross-matched and kept in hand.
Only blood is kept in hand, or what else you have to keep ready apart from blood and the blood products?
Excuse me, ma'am. 40 minutes are over.
Okay.
We have to wrap
Okay.
up.
We are just going to that only.
Yes, ma'am.
Just we'll like in 2 to 3 minutes we'll be concluding.
Yeah.
Yes.
Yes. So almost we have completed like almost everything, like placenta, abruption, accreta and all.
Yes, ma'am.
So what else would you like to keep ready, Chandana?
Ma'am, blood, FFPs, and platelets.
Apart from the blood products, I said.
Apart from and ICU availability
Mm-hmm.
and
In OT, what would you like to keep ready?
ma'am, since there may be a risk of massive hemorrhage, balloon tamponade should be kept ready.
Yes. All the sutures.
But in your whole management, counseling is missing. Counseling is, you have not counseled the attendants till now. So you have to counsel as well. Whatever you are going to do, and you have to counsel and you have to tell each
Yes.
steps and
Yes.
take consent from the attendant as well, and you have to explain, right?
Yes,
So you
ma'am.
have not told about the counseling part. So counseling is very important in such patient, especially you have to tell about the all the complication as well as for hysterectomy,
Yes, ma'am.
right? So
Yes, ma'am.
as you have told that we have to prepare everything and we have to inform all the departments. So you need to have a supporting staff, help of support, takes our help of supporting staff as well.
See, your everything should be ready. Your supporting
is very
staff should be
important.
ready. Your OT should be ready. All the medicines, all the drugs should be ready. All your oxytocin should be ready. If you are operating over a placenta previa, it may
Yes.
turn out to be accreta. You may need to preserve the uterus or remove the uterus. Anything. If you have to preserve the uterus, if it's a placenta previa, you have to keep all the oxytocin ready. Enough oxytocin, methargin, prostaglandins. All the sutures should be available. Balloons should be available. Right. So everything,
Yes,
all neonatologists should be informed, anesthetists, you're all helpers who will bring the blood bank should be informed. So in emergency, everything should be ready. In your PPH tray should be ready. Your PPH tray, you should be always checking from time to time whether all the things have been replenished or not. So all the
Yes.
things should be ready before, and as madam has said, counseling and consent is the most important part of the procedure before proceeding for any type of surgery, because patient may require obstetric hysterectomy anytime. So you have to counsel the patient. Consent is very important. Okay.
Yes, ma'am.
Yes. So Chandana, you have presented it
Counseling
very
and
well.
documentation. Documentation as well, ma'am. One part.
Yes.
That the documentation should be there of each and everything. That whatever we are counseling, that should be documented.
Yes.
So Chandana has presented very well.
Yes.
Thank you.
You have not shown us your face, but
Yeah.
your video,
Ma'am,
your camera is not working.
Yes, ma'am. There's some issue. I have tried
Okay.
it.
Okay.
Coming.
So all the best, Chandana, for your exams. Do well. You have done well here.
Thank you, ma'am.
Although we could not cover all the things, but most of the things we have covered. So these are the questions you will be asked in your exams. Most of these questions will be asked.
Thank you, ma'am. Yes, ma'am.
You have to read the recent advances also. There are many recent advances that have come up in like patients of accreta now. So many conservative surgeries, they are available now. So you have to go through those also, which you could not answer. Okay?
Yes, ma'am.
Yes. So thank you so much, Chandana, and all the best.
Thank you, ma'am.
Thank you,
Chandana.
Dr. Padma, ma'am, and Dr. Moshmi, ma'am. You were very wonderful examiners and very patient too. Your knowledge is also immense, and I'm sure all the postgraduates would be all these questions would be very beneficial to all the postgraduates, and they would have gained a lot from this. Now, for our next session, Dr. Chandana, please share the slides of the chairpersons. I would like to invite our chairpersons, Dr. Archana Verma, ma'am. Dr. Archana Verma ma'am is MD. Dr. Archana Verma ma'am, slide Chandana. Dr. Archana Verma ma'am is MD FICOG, Associate Member of RCOG. She is passionate about creating awareness on women's health. She has been Vice President of FOXY 2000 in 2021. She is Founder President of West UP ISOPAP Chapter, Advisor of UPCOG, Organizing Chairperson of UPCOG, Past President Ghaziabad Obsgynae Society, Organizing Secretary of North Zone UA FOXY Conference 2016. Chairperson of Public Awareness Committee, member of Rotary Club, executive member of NNF India, and executive member of Endocrinology Society Committee of SAFOG, and executive member of AOFOG Onco Committee. Welcome, Dr. Archana ma'am. Our second chairperson for today is Dr. Shipra Sonkusre ma'am, who is MD, DNB, MNAMS, FICOG, MRCOG, and fellow of Gynae Oncology. She is additional professor at Obs-Gynae Department of All India Institute of Medical Sciences, Nagpur, with more than 20 years of experience in the field. She has done her MBBS from JIPMER, Pondicherry, and MD from PGI Chandigarh. She completed her training and fellowship in Gynae Oncology from Prague, Czech Republic, and Rajiv Gandhi University of Health Sciences, Karnataka, under Dr. Somshekhar. She's a trained robotic surgeon. She has been chairperson of Gynae Onco Committee of Karnataka State, and also she is a member of many oncology committees such as the American Society and the European Society. She has more than 40 indexed publications, delivered numerous lectures and presentations, and is on editorial board of various journals. She's the investigator of various projects with international funding. So welcome, Dr. Shipra ma'am. I would request the chairpersons to please introduce our speaker for today, Dr. Aruna Nigam ma'am.
Thank you, Dr. Neha, for the kind introduction. It's my privilege now to welcome and invite Professor Aruna Nigam for the lecture tonight. She's head of the department at Hamdard Institute of Medical Sciences and Research, Jamia Hamdard, New Delhi. She has immense record of H-index of 20 and I-10 index of 36 with so many citations. She has her own website, learning website and education website with more than 200 video lectures and so many subscribers. She is editor for 6 books and is editor of 3 journals with more than 200 index articles and chapters published. And she has delivered more than 100 lectures with such an impressive CV. She has her areas of interest in medical education as well, along with the skill-based training, and in gynecology and obstetrics, she has interest in gynecondoscopy and high-risk pregnancy. So with this impressive CV, we are privileged to have you here, madam, and to listen from you. Welcome, madam, for the lecture. Now, madam will be delivering lecture on perioperative challenges in the management of antepartum hemorrhage. Welcome, madam. Over to you, ma'am.
Thank you, Dr. Shipra. Am I audible?
Yes, ma'am. Yes, ma'am, you're audible.
Okay, thank you, Dr. Shipra, for such a nice introduction. And I think मेरे लिए तो कुछ छोड़ा ही नहीं है, Dr. Padma, Chandana और Dr. Masmi ने सभी कुछ cover हो गया. So I'll just go through few of the things just to give you an overview, because it is very difficult to cover each and everything in the perioperative. The topic which has been allotted to me is perioperative challenges in the antepartum hemorrhage. So it will be sort of, although I cannot see my delegates, because without eye-to-eye contact, it is quite difficult to make that memento. But still, I have, if all of you allow, I have written few points regarding the management, regarding the previous case, so that it will add up, if you allow me for the same. Is it
Please,
allowed?
ma'am.
Okay, thank
Yeah,
you.
please, ma'am, go ahead. Please, ma'am. That will be a
Thank you.
privilege.
I have opportunity to interrogate Chandana in my previous practical course also. So Chandana, you did very well, and it was much better than what you have done last time. You were novice at that time, but at that time also you were very good, and this time you have improvised a lot, and it is really a very good thing. So few things to start with. Whenever we are presenting a case, I have some amount have been left, but in abdominal girth, when you mentioned, it was in centimeters, so it should be in inches, I think. Right? So that is a very important point, because these are the final points by which the examiner judges you. Then in your diagnosis, you have written morbidly adherent placenta. Number one thing, you cannot, on the basis of the history and university, just by examination, you can label it as a morbidly adherent placenta. You should be just writing down placenta previa, or if someone tells you during history that I had a placenta, this diagnosis has been told to me, so you should be writing down a placenta accreta spectrum, because you at this time don't know that whether it is a grade 1, grade 2, grade 3, and that classification should be mentioned once you are having an investigation. So there is a FIGO classification regarding this placenta accreta spectrum, which you should be saying rather than saying accreta or increta or parcreta. If you use that will tell you in a better manner, and everybody will say, okay, you know this classification, or you can direct your viva towards what you know, right? That is the thing. And another important thing regarding the sensitivity of the ultrasound and the MRI, which can be asked to you during your exam. So ultrasonography sensitivity and MRI sensitivity diagnostic accuracy is almost absolutely same. Right, so both are same. It depends upon the operator who is doing this ultrasound. So you should be, and you can be asked, what are the very important, most important points when you are doing an ultrasound? Although there is an ultrasound-based staging system for this placenta accreta diagnosis and making a diagnosis of accreta, increta, parcreta, but there are few very important points which any novice can also see. So those should be known by you. That can be asked. That means the lacuna and the interface and the endomyometrial and bladder junction. These are the three very important points. And another important thing, when the MRI becomes more important than the ultrasound, that is again a very important point. So MRI becomes more important whenever the placenta is posterior, because ultrasound is not able to diagnose the posterior placenta accreta, parcreta. So it is very good that if you do an MRI in the posterior placenta previa and in the obese patient. So these are the questions which can be asked. There are few things which when I'll go and lecture, I have not made many slides for all of you. So we'll just, I'll go sharing my screen. So I'll share my screen, and where is my lecture? Okay, right here. So Dr. Prachi, please tell me the time. I think I have already invested 5 minutes, so I have left with 20 minutes. 30 minutes you have given, so I have 20 minutes. 5 minutes I can have a discussion, because once I start speaking, I forget the time. So please take care. I request my chairpersons also to please tell me whenever it is a time. Right. So whenever I'll go with a slideshow from current slide, right? So perioperative, this is a very important thing, and we need to have just in mind whenever we are dealing with the perioperative challenges, because when you see a lot of blood, patient is bleeding, and you have started a NOR and a drip, what happens? Your senses go. So this is the thing, your mental stability as a surgeon, as an obstetrician is very important. That is why you need to have, and you need to be anticipating all the challenges which can have in the management of APH, whether it is an elective section or an emergency section, because elective can become an emergency also. So you need to have in mind as an obstetrician, because the incidence of this accreta, parcreta, previa, all are increasing day by day. So basically, what is your aim? To save mother, fetus, and the uterus. Am I right? Let me take, oh, where is my pen? Okay. Right. So what is our aim? Our aim is to save mother, fetus, and uterus. But if you have option, patient is bleeding, right? Patient is bleeding, baby can go exsanguinated, then what is your aim? To save fetus? वो पिक्चरों वाली बात हो जाती है ना, एक माँ को ही बचा सकते हैं या बच्चे को ही बचा सकते हैं, ऐसी कहानी होती है, ठीक है ना? So what happens? What is your aim? Your aim is most importantly to save the mother in the emergency case. Always remember. So you have to decide upon your line of action should be that you should be thinking like that. The main important thing is the mother. But then, yes, if it is a primary, you will like to save the uterus also. And fetus, of course, if you can save a fetus, yes, fetus also count. Because once you go for a hysterectomy, she is where? So everything is important, but then depends upon the clinical situation. What is your priority? Right? So always remember, you have to save mother, fetus, and uterus. But what is your priority when the patient is bleeding? Mother, uterus, or the fetus? So that ways you have to think on. So whenever you are taking any patient for a surgery, the challenges differ whether it is an emergency section and whether it is an elective section. Because if elective section is there, you have availability of Dr. Padma and Dr. Mosmi or Dr. Prachi. But if it is an emergency cesarean, you might not have availability of all those. So always take these patients as an elective. That is why once you have said, I will take the patient as per RCOG guidelines, 238 weeks, remember that in your history, you told that your patient is coming from how much distance? 100 kilometers. कब एडमिट करेंगे आप उसको? कब इलेक्टिव सेक्शन करेंगे? कौन सा महीना चल रहा होगा? रात का होगा, दिन का होगा? So your guidelines are always there to guide you. But you have to decide the things according to your environmental, your availabilities. So you can go for a termination in this case at 37 and even for a 36. Why? Let me tell you. This is a case of previous cesarean. You are already diagnosed it as a placenta increta. You have told that it was invading the myometrium, although bladder was not invading. So she becomes a very previous history of myomectomy, previous history of placenta previa, all they are going. And in the first trimester, it was a low-lying placenta, right? So all this makes that your patient might need some extensive surgery. So there is no harm if your NICU facility is there, terminating it at 37 weeks. And now, whether it will be 37 completed weeks or 36 weeks, it depends. Or even 36 weeks, I can go for all these cases if the patient is coming from 100 kilometers, or I will keep that patient admitted with me and I will ensure my availability in case of emergency. Always remember, if they have a spotting at 34 weeks, 35 weeks, 36 weeks, they are the alarming signs for these patients that they can go into a hemorrhage. Now, another point very important. Do you think placenta increta bleeds? Is it the placenta previa component which is bleeding or placenta increta? See, if it is invading the myometrium, there is no place for separation unless you are doing a cesarean and then notifying it. Simple thing. ठीक है ना? So always remember these are a very important points. तो अगर patient नीचे से bleed कर रही है ना, तो मैं तो बड़ी खुश हूँ, क्योंकि chances of previa are more, increta are less. ठीक है ना? So these are the clinical. Everybody don't have an institute like KIMS everywhere. MRI, getting MRI, 4 times ultrasound. And why will you get an ultrasound again and again and again? Once you have made a diagnosis, you do it for fetal well-being. Patient has come to you at 36 weeks. Okay, it is you have decided. Now again, you want to do a placental localization. So placental localization will be there to decide upon the incision over the uterus. Not it is because of you again want to rule out that it is increta, accreta. If once it has come to be increta, treat it as an increta. Go with a higher version. It भगवान तुमको सेव कर रहा है अगर कम निकलेगा. But think of the higher thing in these placenta accreta spectrum disorders. Now, for successful outcome, your 4 things are very important. You should be having a good blood bank facilities. Don't operate the patient if you don't have a blood bank facility. Working blood bank facilities, providing you with all the blood components. Very important. Team of experts should be there because now you have Dr. Shipra, who is a trained oncologist. So it is a boon for you to have an oncologist in your team. Right? So team of experts will be there, but obstetrician, now I will go back and say, are each and every obstetrician should be trained for this surgery. Make a team with a surgeon, make a team with a urologist, but make a team with your own obstetricians. because these are your cases, anytime emergency, वो क्यों आने लगा, आप प्राइवेट में बैठे हो, or they will charge hugely. Something like that can happen. So team of experts is very important. Make a team if you are sitting in a private, or you should be knowing that who to call. उस वक्त नहीं होता, उस वक्त you cannot call सर्जन को कॉल किया, आज उनका कॉल डे है तो हम उन्हीं को बुला सकते हैं, ऐसा कुछ नहीं होता है. For these things you need to be decided in your protocols, in your SOPs if you are working in an institute, that whom to call, whom you have a reliability, right? So now going good investigation facility. Now why you need आपने तो अच्छी सर्जरी कर दी, but again these patients are examinated. Now their perioperative management in the form of blood and blood products and the fluid is very important. And that depends upon your investigation. You should have an emergency facility of each and every investigation, whether it is a ABG, LFT, KFT, because now if it will go haywire, your post-operative patient will become an exsanguinated in whom you have operated so nights. So good ICU with a good backup of your anesthesia team have to be there, and that comes into your perioperative management. Now coming to right. So now I'll go back to the learning objective. So I cannot cover whole of the topic in this short span of time. So I will be taking some amount of massive transfusion protocol, which Dr. Mosmi has also said. The principles of the surgery, somewhat new things I should be telling you. So triple pre-procedure and post-operative care is the time permits. So let me ask you, what is massive transfusion protocol? When do you say it is a massive blood transfusion? Do you know, Chandana, can you tell me, you were presenting a case? What is massive transfusion? When you alarm it that yes, you have to indicate that this is a massive transfusion protocol which should be started. It is not just like that कि आपने कह दिया massive transfusion protocol हो गया. Can you tell me, when do you call that this transfusion should go to now massive transfusion protocol? So whenever there is a need of the blood transfusion of more than 4 points in a 1 hour time, then this patient now lands up into a alarming system of massive transfusion protocol, and like alarm system of your shoulder dystocia, your BPH drill, cord prolapse, you have to alarm that now we are starting with a massive transfusion protocol, for which your pathologist, your reporter, your person bringing the blood, your investigation facility should be alarmed, and it has a definite protocol. So if the need of 4 blood transfusion in an hour's time, or more than 10 blood transfusions in a 24-hour time period, then you start with a massive transfusion protocol. And what is your purpose of having a transfusions? So your hematocrit level should be more than 25 to 30%. Your platelet count should have an aim of keeping it more than 75,000. Fibrinogen should be more than 300 milligram per deciliter, and PTA, PTT should be less than 1.5 times of the control. That should be the purpose of any transfusion, and this will remain as a protocol, because MTP protocol, after every round of transfusion, you are going to send these investigation, and immediately in a 10 minutes time, you should be having this so that you can go with the second round of transfusion. And the book which I have showed you, or you can go to FIGO guidelines, you can go to anything, but you should be reading. This is the latest book which I have, right? So now, suppose you are operating in an emergency, आपने देखा blood bleeding start हो गई. जब start हो गई, तो आप blood के लिए wait करोगे, resident को दौड़ाओगे, है ना? What this will happen? But क्या, whether your blood will be available immediately? No, your blood will not be available. Now, what transfusion should be done when this patient was in labor room? What transfusion to be done when she is in OT? It's not the responsibility of the only anesthesia team. It should be there. So now again, what is the purpose of transfusing the fluid at that point of time? That your urine output should be more than 30 ml per hour. You should be keeping the mean arterial pressure of more than 70. And can I ask you, why do you want to keep this 70 ml mean arterial pressure? Why do you want to keep it? Everybody says mean arterial pressure should be. Number one question can be asked, what is mean arterial pressure? What are the importance areas when we talk of mean arterial pressure? And why during the PPH or APH, when we are transfusing, what we should be keeping MAP of 70 mm of mercury? Because if it goes below the 65, the heart will not able to contract. इससे कम में नहीं कॉन्ट्रैक्ट करेगा, इट विल गो इनटू फेलियर, मायोकार्डियल इश्यूमिया हो जाएगा. सो यू नीड टू कीप द प्रेशर अबव सो दैट यू कैन हैव अ एंड डायस्टोलिक वॉल्यूम ऑफ दिस मच सो दैट योर हार्ट गोज ऑन contracting. Coming to the fluids, which fluid at what ratio are you going to transfuse? So I hope you all will be knowing that you need to know how much estimated blood loss is there, and you have to transfuse more than 3 times. One, if there is a 1 point blood loss, you should be transfusing 3 times of the crystolite. Now the question comes, which fluid to be transfused? Which fluid to be transfused? So you can give RL or NS. Don't give the dextrose, because dextrose get metabolized and it is only the water. And the water will go now in the extracellular space. So for the time being, you need to transfuse RL and NS. And better if you have a facility of plasma light P. This is simply a different composition because it has got a less lactate level. When the patient is losing, what happens when you are transfusing a lot of lactate? It is causing a increase in the lactate levels and it is causing a metabolic acidosis. See, the metabolic derangements are very common in the patients whom we are transfusing a lot of fluids in the blood. So this management should go hand in hand whenever we are managing this patient. It's not only necessary that you should be knowing the surgical challenges. No, perioperative means the fluid challenge also you need to know. You need to know the antibiotics, you need to know coagulation factors and everything. So always remember RN and LN. If you estimate the blood loss is 1 liter, you transfuse 3 liters of fluid to this patient till you are getting the blood. Now, if you are getting a blood, you are a lot confused how much to blood and blood product to transfuse. So simple formula is still 4 blood you can give. Otherwise, if you have a facility, go with 1 of blood, 1 PCV, 1 platelets, and 1 FFP. So 1 FFP, 1 platelets, and 1 of the PCV. So this ratio of 1:1 should be maintained whenever we are doing. Now, okay, now you have announced you have needed the 4 transfusions. Okay, so now you have to announce that the massive transfusion protocol has to be. So here, these are very important point that you need to know who is the runner in your team and who is the reporter in your team. Okay, and every time you are doing this transfusion, you need, after every round, you need to have these investigation: hemoglobin, TLC, hematocrit, platelet, and APG. Very important, and a coagulation profile, and this value should come. So in MEMTP protocol, there are generally 4 rounds, as this is shown in this figure. Right? So 4 rounds are there, and these are in the ratio of 6 of PRBC, 6 of FFP, 6 unit of platelets, and 10 units of cryoprecipitate. And then you send the investigations, see it, and again, if everything is bleeding is controlled, your parameters okay, you announce that it should be aborted. But it's still not controlled, you will go for a second round, similar 6 into 6 into 6 into 10. Right? Again, you will send the investigation, and 3rd round will be of tranexamic acid. Here you wait for some time, and then again the 4th round if your parameters are still deranged. If the patient is controlled, you always have to announce that we abort the MTP protocol. That has to be done because your blood bank is preparing everything for you. And this blood, if once you have thought the FFP, it cannot be reused if you are not using in this patient, right? And unnecessary transfusions are also not to be done so as to have a minimizing the transfusion reaction. So these are the basic points which should be following this much, and you should be going back and reading this MTP protocol. Now coming in which everybody is interested, principles of surgery. So perioperative management, this blood पानी ब्लड आता रहे चढ़ता रहे तब आप चैन से सर्जरी कर सकते हो, नहीं तो कुछ नहीं कर सकते हो. Remember that. Now coming to the whenever we are talking of a surgery, one thing I have left here, I straightforward reach to the incision, but what should be the ideal position of surgery? So whenever you are taking up this patient, the ideal surgery is a lithotomy position so that simultaneously you can assess the blood loss vaginally also. एक बार यूट्रस बंद कर दिया तो आपको तो नहीं मालूम चलेगा ना. So you should be assessing vaginal blood loss also. So your patient should be ideally lithotomy position. Remember this thing very clearly. Now the abdominal incision, very nicely told by Dr. Padma, that it should be, or Channa, that this should be a vertical incision preferably. But if it is an emergency section, you have not thought of that, you have a tendency for a cosmetic incision, it will be a transverse incision. Right? So you can face a problem if you are not able to do the things in this incision. You can go for the making it a good abdominality, no harm. The aim is again to save the uterus, right? So once you have opened the abdomen, the next important point is you have to inspect the uterus very nicely. Because why you want to inspect? You need to see the vascularity over the uterus. You need to if this is the uterus, you need to see the vascularity. If the placenta is still here, lot of vessels are there, your incision, now you have to decide. You want to cut the placenta? You don't want to cut the placenta. You want to remove the placenta? You don't want to remove the placenta. If the vascularity is true, you are thinking or you know that this is increta, you can go without removal and that will cause less bleeding. Increta bleeds only because you are fiddling with the placenta. Otherwise, it will not bleed unless until you start. Another very important. So, where should be your uterine incision? It should be 2 centimeters above the line of where you are seeing the maximum vascularity. Right? So that you are totally saving the placenta. It could be vertical, it could be transverse, whatever you are feasible, it's no problem. It can go to upper segment cesarean section. Right? So this is the point. Now you have to decide, are you going to remove the placenta or are you not going? You have taken out the baby. Are you going to remove the placenta? If yes, then you give oxytocin. If you are not going to remove the placenta, you are going to judge it, then please avoid giving oxytocin because this will stimulate the separation of the placenta. It's not necessary your whole thing is increta. It might be somewhere it is accreta, somewhere it is increta, somewhere it is only a placenta attachment. So avoid giving oxytocin if you are planning the patient for a conservative management, leaving the placenta and you don't have expertise to do. This will save the patient life. So I hope you understand why I have written the uterotonics. Otherwise, use the uterotonics in a similar manner. Then the placental management, a very important point. So if you have planned that this is the incision, you have given upper segment, you are not going to remove the placenta or you are doing to do obstetrical hysterectomy. Before this, you don't have an interventional radiologist with you where you have put in an intra-arterial balloon. So now your abdomen is open and you need to know how to do internal iliac artery ligation. Right? So you need to do the internal iliac artery ligation. Here, the uterine artery ligation is not going to do anything. Internal iliac artery ligation, and how does it help? It decreases the blood flow, makes the arterial flow to the venous flow. And where do you ligate it? You ligate it in the anterior division 3 centimeter from the division, right? So it is easy, not very difficult, just you have to try and get trained for the same. Remember that for 5 centimeters in the anterior division, there is no branch. So this is a area where you can easily do the ligation by just insinuating your mixture beneath it, right? SWD, I have written, if you have removed the placenta, placental bed is aiding to SWD. Always remember, SWD does not include the internal iliac artery ligation. Right. Then hemostatic sutures, you people have answered the hemostatic sutures very nicely. So this is the placenta which is bleeding. Prachi, time ho raha hai kya? How many minutes left? You are muted.
Ma'am, you can go on, please. We are loving to listen to you. I think Shipra ma'am would tell better. She's the chair, so I
Yes.
think
No,
like
no,
to listen to ma'am.
Dr.
Very true.
Shipra, please.
Very true.
नहीं
Yeah,
नहीं
I think
no
it's
no
going very
20
well. I
minutes
think, yeah,
20
we are
minutes
loving
is
the
a listening
lecture.
time period.
Yeah.
सब चाय पीने खाना बनाने खाने चले जाएंगे. I know that.
मैम वो
ठीक है.
कोई और स्पीकर्स होते हैं, अभी आपके पास है ना, आप बोलिए मैम.
Okay, so now hemostatic suture. I'm just taking few points because each and every need 30 to 40 minutes. Hemostatic suture. Now remember that this is a lower segment which is bleeding. तो अपर सेगमेंट के बी लिंच क्या फायदा करने वाले हैं? डू यू थिंक बी लिंच कुछ फायदा करेगा? तुम लोग ने आंसर दिया बी लिंच की कहानी कर दी. बी लिंच will not help because upper segment is not bleeding. It is the placental bed and the lower segment which is bleeding. So you have to take the sutures. If the atonic uterus is there, then only this will help. Otherwise, B Lynch is not going to help. Now, what to do now? So you have to do either vertical ischemic sutures you have to take और ट्रांसवर्स सिस्टमिक. अब ट्रांसवर्स लिया तो और प्रॉब्लम हो गई कि आपने तो ऑस बंद कर दिया तो ब्लीडिंग कैसे मालूम चलेगी? एवरीथिंग विल बी कलेक्टेड. सो फॉर व्हेनेवर वी आर यूजिंग tying up the transverse suture, we are putting one cannula inside. And it is a very good idea to put a panikar cannula, which causes a negative pressure also, decreases the bleeding also, and then you tie it here, or simple suction cannula can also do. Right? So transverse ischemic sutures along with internal ligation. Another suture which is helpful, you see, going outside and then coming chow sutures upper segment में use किया जाते हैं. But here what you can do, supposing this is your lower segment. Remember that a very important point, that placenta is not implanted in the cervix. It is planted in the lower uterine segment, which is formed by the isthmus and which is the enlarged area between the histological and the anatomical internal loss, becoming 7.5 centimeter till pregnancy. So it is never the cervix involved. Remember this point. And I'll tell you why I am telling this point. So remember that placenta is, तभी तो ट्रांसवेजाइनल सोनोग्राफी करते हैं और सर्विक्स को देखते हैं और उसके ऊपर तुम्हें दिखाई पड़ता है. दैट इज द थिंग, द पेरिनियल अल्ट्रासाउंड और ट्रांसवेजाइनल सोनोग्राफी, यू ऑब्जर्व योर सर्विक्स एंड उसके ऊपर प्लेसेंटा. सो इज इट implanted in the cervix? No, it is never implanted in the cervix. Remember this point. And I tell you why. So you give these, suppose this is the wall. So you go deep. Don't cross the outer layer of the myometrium, just in the middle layer, and come back and tie it. Come back on the other side also and tie it. This will decrease the bleeding of the base of the placental bed. Don't go through and through. Through and through जाने की ज़रूरत नहीं है. Okay, and this is the way you can take a placenta. This can be a figure of 8 or box suture, whatever way your purpose is to just close the bleeding. What suture you will use, catgut तो हमारे यहाँ available नहीं होता. Maybe whatever is available, we are using a vicryl suture. There is no problem in using a vicryl suture. मरीज बचाना जरूरी है, vicryl टूटता नहीं है, बड़ा आराम है. Am I right, Dr. Shipra? Vicryl we are using in general.
Yes, ma'am. I think vicryl is the sutures which is used today because catgut is not available almost anywhere.
Yeah, it's not available. Even for ligation, it is not available. And for that matter, we are using a vicryl rapid.
Yeah. Even for Billinch also, even number 1 Vicryl is the one recommended now.
Yeah, that's very right. So you should be going with the latest suture. Very new, I just thinking to tell you, this is one Comoc MG suture is available. This is the latest thing which I thought I have included in my book also. Comoc MG suture is available, which has got a needle straight, because this is a problem which we face. Curved needle and a straight needle. Right. So what, with a single prick, you can do a breelage along with a uterine artery ligation with this suture, right? Because there is a problem of getting a 8 centimeter straight needle in your OT. This is a practical, and at that time we are straightening our round body needle to take the wheeling suture. So Comoc MG is a new invention by Dr. Mahesh Gupta of Gujarat. So this can be Suture India supply. So this I have talked. Now a hysterectomy, somebody told, hysterectomy is a thing which you should be. So agar patient आपकी NORAD पे चली गई NORAD पे, please don't go for these conservative thing. Aim is to save the patient. Go for a hysterectomy straightforward. There's no sense if your patient has gone into NORAD, patient is bleeding, go for a hysterectomy. I am not because everybody is not able to do the internal iliac artery ligation. So don't do this heroic surgery, because then coagulation deranges with a lot of blood loss and everything. And now I was telling you the obstetrical hysterectomy concept, which is very important. I told you that this is a placenta implanted in a lower uterine segment. Right? Why do you want to remove the cervix? Because it will take more time. That is why the lithotomy position is good. So if you are reaching below the internal os, below your placental limit, leaving this part of the cervix, saving the time, you will be removing whole of the placenta along with the uterus. It is not implanted in the cervix, always remember. And the bleeding which is occurring from the down, it is from the edges which you have not sutured in a nice manner, in a full thickness manner. It's most of the time it is. So it is not necessary to remove the complete cervix if you have a problem in reaching up till. So your subtotal hysterectomy, that is a typical of the obstetrical hysterectomy, will do all the justice. Now you have to see the limits of your placenta. Placenta never go in the cervix. Always remember, this is the anatomical concept. It is always in the lower uterine segment, not in the cervix. Right. Now coming to one new thing which I want to tell you is a triple pre procedure. It has been given in 2012 by a मैंने ये लिखा है कि तो प्लान योर सर्जरी, ओटी के अंदर घुसते जा रहे हैं और प्लान करते जा रहे हैं. योर मॉडरेटर्स आर वेरी नाइसली टोल्ड दैट प्लीज प्लान योर पॉइंट्स. दिमाग में चलते रहना चाहिए, मुझे क्या करना है, किससे क्या कहना है, किससे असिस्टेंस लेनी है, किसको फोन करना है. एवरीथिंग शुड बी प्लान. व्हाई आर यू वॉशिंग, गेटिंग द पीपल अराउंड यू रेडी फॉर दिस emergency. So this is a beautiful article. You can go 2012, published by Edwin Chandranan, and he is really a very good obstetrician. So triple procedure, whenever we want to save the uterus, we can go for this, and we know that this is a placenta previa. So what is there? We first do a peripartum. We admit the patient 24 hours prior. We do a peripartum localization of the upper placental edge, and this can be done in the OT. Then we go for a pelvic devascularization, and this pelvic devascularization can be done with the help of, before we can take a help of an interventional radiologist, where he or she puts an intra-arterial balloon. Okay? So in the morning or one day prior, this intra-arterial balloon can be there. Then what you do, you don't see the, you see where the placenta is adherent. It can be at one place or some more area. So what we go, we take, suppose this is a placenta, this is a uterus, and here is the adherent part, or this much is the, we excise, we take out the baby with the upper segment cesarean section. Then what we do, we immediately inflate this balloon, which is there in the internal iliac artery or uterine artery, which will decrease the blood supply. So after removal of the baby, you inflate this. Okay. The ultrasound machine in your OT will help you to relocate that this balloon is still inside at a right place, because you are shifting your patient from the radiology or from your pre-op area to the OT table. Okay, so this should be there and you should be confirming this inside, or you can go for a internal iliac artery ligation. Now what you do? You excise this whole myometrium a bit. Myometrium is quite hypertrophic, hyperplastic myometrium. So even if you remove the big chunk of the myometrium, you will be able to approximate the edges, which is a common problem. But you cannot do this procedure whenever there is a lateral implantation of the placenta and there is a lateral invasion, or there is a posterior invasion of the placenta. Got my point? क्योंकि पीछे का नहीं एक्सरसाइज कर सकते, it is not possible. So whenever there is anterior excision, you need to do this thing. So if you are planning this procedure, take an informed consent, ultrasound, MRI, pre-op, interventional radiologist. I already talked about this. Abdominal incision, they say you can go with a transverse incision, and this you give, suppose this is an abdomen, right? Okay. So you give a St. George incision over the rectus. So वो कहते हैं आप transverse ही खोलिए. Then you open the rectus in a board-shaped manner. And what you do, you separate this fat in a very nice manner to give this board-shaped incision. Okay, so this will give you a good mobility. Otherwise, we go for a vertical incision. Then your uterine incision. I hope मेरे ये writing समझ में आ रही होगी सबको. Okay, so now you have removed a good chunk of, suppose this much amount of this myometrium, right? Now how to approximate? This is a big problem. In myomectomy also you approximate. So what is the problem? Now what we are doing? We are taking a box suture first to approximate this area. You can do single layer closure also. So you take first box suture so that this myometrium comes nearby, and then you do a one closure again. Right? Even a single closure, if it is not bleeding, there is no problem. Keep the balloon inflated for next 4 hours. Keep watch over the vaginal bleeding. If doesn't bleed, remove the arterial balloon. Otherwise, you can keep that for 24 hours. Remember that you have to remain 2 centimeters above the bladder reflection. Why? If you go too low, how will you stitch? So always remain 2 centimeters below the edge of the bladder, right? So I think I have talked a lot. So build up your team. Experts should be present. Blood and blood products, very mandatory, and there are a lot of things to learn for this. We should be having a regular antepartum management protocols with us and a good post-operative care. क्योंकि आधे मरीज तो हमारे इन्फेक्शन से और ट्रांसफ्यूजन मिसमैनेजमेंट से एक्सपायर कर जाते हैं. That is a misfortune because we are dependent on our anesthetist or a medicine paper. Right. So this finishes with my lecture, and this is my day after tomorrow on 4th November. I have a lecture on surgical pelvic anatomy for 2 hours. I invite you all to attend. You can go to my website and do the registration. Today is the last date of registration. It is not costly, but go for a registration if you want to read. This is the other 2 books which I have released in 2023, and these are my website, more than 200 lectures. These are different modules where you want to learn the surgeries, this triple procedure. Each and every surgery has been shown on the patients and with all the steps of the surgeries in these modules. And yes, it was very difficult to make them. Very difficult. And I have not included a laparoscopic surgeries, I told you, because this is full on the YouTube. So thank you all for your patient hearing. I think I could have done the justice with the topic allotted to me. So thank you, madam. If there are any question on the chat box, I am ready to answer. Or chairperson
Was
can answer.
really
I'll keep
excellent.
quiet.
Really, no doubt. Very good practical tips.
Shipra ma'am.
Yes, I think now I got to know why Aruna Madam is such a wonderful teacher and has so many subscribers to all her courses and the website. I was really impressed by her passion to teach the students and how she explains with illustrations and diagrams on the board. It's really impressive, Madam. Thank you so much for the wonderful lecture. Not only the postgraduates, even I got to learn something like the myometrial excision after the balloon has been placed in the iliac arteries. That's something which really I have never tried before myself, and I think something worth watching or worth looking for. And really, madam, thank you so much, and really thank you for actually talking about the PAS or the spectrum, introducing the word spectrum. Basically, we missed out on that word, and then you spoke about it, and also telling us that the posterior placentas are difficult to be located on ultrasounds, and even the diagnosis is not very conclusive if the placentas are posterior, and it's confusing, and hence we should go for a higher imaging modality when the ultrasound is showing a posterior placenta, and we have a doubt about the placental location, especially when the placenta is posterior. And definitely the anticipating the sequence of events and what can go wrong, and be prepared for everything. That is the best modality in a case something like this. And the slides were very impressive because they were very simple. I really enjoyed the slides because such simple slides with so much of information, and with just one glance at each slide gives you complete information and what to take from each slide. That was also very impressive. Educative slides, simple slides, and all the practical points which madam has taught us, which are not given in books, something like which madam has reminded us too many times that that placenta is in the lower uterine segment and not on the cervix. There's something which will not be given in any book, but yes, it's a very practical point which madam has told us, and I was completely mesmerized. And madam, thank you so much for teaching us so much. And I think we can have madam for many more lectures now. It's really
Sure. Everyone
Thank
was
you, madam.
mesmerized.
Yeah, I will request all the delegates if they can attend the surgical pelvic anatomy. I really tell you, the concept will be made. Nobody has taught me like this. I have gathered all these things with my experience, and I want to share that experience with everyone, because I think we should be enjoying our obs and gynae. We should be enjoying. So you need to know, if you want to enjoy the surgery, you need to know the surgical relevance of each and every part of the pelvic anatomy, even if you are giving a episiotomy.
And really, we realize that you are so passionate about all these things, and you really find out the way. It's really excellent.
Thank you so much, ma'am, for joining in. And of your 5 years given to Lady Harding, I mean, I was the lucky person who was there for 3 years. So as your PG student, and just wanted you here. I talked before also, but you didn't have time at that time. So thank you so much for giving your time to us and spreading the kind of knowledge in this Vidarbha region too, like the students directly, and then it is spread over, like in the YouTube link goes on globally. So I'm sure that all the students will be privileged and they will get access to your lectures also. Thank you so much, ma'am.
Thank you so much. Thank
We'll
you.
have one photograph also now again. Corona people, please.
Chandana, you may also please join in.
Please, yeah, please open your windows.
Bhakti ma'am is there.
Bhakti, please.
Somebody remains. I don't know if there is some participant who's Moshmi ma'am is also there.
चांदना, अगली बार मैं तुम्हें बुलाऊंगी प्रैक्टिकल कोर्स में, प्लीज तुम्हारा वीडियो ठीक हो जाना चाहिए।
मैम हमको भी बुला लीजिए, हम भी आ रहे हैं।
ना ना, तुम लोग को जरूरत नहीं है।
But every time we learn different concepts from different
Yes.
persons. So every time we are also student.
Yes, we learn from each other. That's a very
Yes.
good one.
Ma'am, we also attended all your last surgical pelvic anatomy class, and we learned lots of new things.
So
Not
great.
new, but maybe we missed out when we were learning in our postgraduate days. But that was a new thing for us to learn.
And I'm the lucky one whom ma'am has operated upon. So my first daughter is born of ma'am's hands.
Oh, so nice.
Yeah.
We would like to invite you, ma'am, again and again.
Yes, sure.
Thank you, ma'am.
Thank you so much, ma'am.
Thank you. Thank you so
Thank you,
much.
ma'am.
Okay. Bye. Take care.
Bye.
So, Neha, you give permission to the MOC?
Yes, ma'am. Thank you. I would also like to thank Shipra ma'am for
Neha, it
being.
was very good. You conducted very nicely.
Thank you, ma'am. Thank you for giving me this opportunity.
Yeah.
Thank you.
Everyone was really good and very, very nice. Even though she presented case very well.
Yes, ma'am.
Sure. We call the meeting.
Yeah.
Thank you.
Yeah.
Okay.
Thank you
Okay.
so
Bye.
much.
Thank you all.